All right, so this is going to be lecture 1 of the 116 slide epic presentation that unfortunately we won't get to see in person. So I'm going to break this up by monitor, so the videos are short and you can pretty much watch what you're going to watch anyway. So first things first, the blood pressure cuff. So measuring blood pressure based off Laplace's law, pressure resulting from tension in the ventricular wall, and Starling's law of the distension caused by increased venous return and lengthening of the cardiac muscle increases force of contraction. So two main ways that it's measured. The old method, manual method. So the sphygmomanometer. So it's, in nursing school, and we did it for lab, and that's pretty much about it as far as manual pressures that we took. Using the stethoscope and oscillation, and then watching like the little thing, hearing the sounds. First sound systolic, last one diastolic. Mainly used with aneroid gauges, because who uses mercury? Named after Korokov or Krotkov, naming the sounds of the 4 sounds here. But the main thing that you'll be working with is oscillometry that we worked with in the hospital, how the automatic blood pressure cuff works. The exact specifics for how it works is proprietary, so the exact equation and formulas we're never going to necessarily know. So it's measuring pressure variations caused by the oscillation of blood flow through the artery. So, as the cuff blows up and tightens, clamping down on the artery to stop blood flow, and then it slowly kind of releases it. It's measuring kind of the blood hitting the sides of the vessels. So kind of here with the, props today. So in this pressure, versus time, pressure millimeters of mercury, because, we live in America. So as it opens up, this is kind of the blood reverberating off the side of the arterial wall. So when it first starts hitting it, that's the systolic blood pressure, as far as where the cuff is at. And then kind of max amplitude of the oscillation, that's the mean arterial pressure. And then kind of the last little faint before it kind of laminars out is the diastolic blood pressure there. So generally speaking, obviously the cuff is inflated above the systolic, and as it deflates, the pulsations are being measured. So the measurement, how we put it on accurately. So the center on the medial side of the arm of the brachial artery. So the length, get your tape measure out, because you've got to be exact here. So the length is 80% here. Then we have the width is exactly 46%. No, it's not 45, it's not 47. The width must be 46%. And cover 2/3 distance elbow to shoulder. Cuff with its tubing connections obviously shouldn't leak. You should know what that sounds like. Also, you're going to put it on probably differently than what you're used to at first, because you're at the head of the bed, so it's kind of like upside down. So you want, where it attaches facing you, not going down this way, but face up that way, so you can disconnect it in a hurry, like when you're getting them out of there. So cuff, the cuff is too small, the blood pressure is too high. If the cuff is too large, the blood pressure reading is going to be too low. So as far as how we're measuring it, important thing to remember is 2 minutes between. You need at least 2 minutes. I'm sure many times in the ICU, how many times you took a blood pressure and then the doctor, a nurse, just gonna wait and had to hit it again and recycle. You're gonna get venous congestion and you're wasting your time because it's gonna be inaccurate. Results are less accurate with dysrhythmias. You know, when they're in VFib, I mean, that thing just can't read anything. And fails to read low blood pressures. I mean, we've all seen it. If it's under 50, I mean, you should be worried about other things at that point. It will tend to kind of overestimate systolic, underestimate diastolic. Some accuracy questionable below 110. It's just kind of one piece of the puzzle as far as the monitors you're using. One that isn't in here that's very important is really learn how to entitle CO2 and really learn how to utilize that in your practice. You know, kind of a shorthand always kept in mind, entitle CO2, the CO, so kind of a cardiac output monitor. I mean, because as the cardiac output drops, then respiration exchange of O2 CO2 will drop. So you can pick that up on the entitle CO2 monitor and then kind of investigate with a blood pressure reading in the meantime if need be. So measuring blood pressure, it's variable. You know, the standing man, pressure 53, 202 in the heart, 202 in the feet, 90 at the heart. So we're always using the level, kind of the right atrium, kind of off center here. Respiratory, so intermittent positive pressure ventilation can lower due to the effect on venous return. I mean, we should have seen this in practice, like with the BiPAP, people on BiPAP, increased pressure, kind of blocking, in a sense, blood coming back. I mean, you're definitely going to see it when you do your, like, gallbladders in the Da Vinci, you know, kind of putting them up like this, big gap with the machine, the venous return can be compromised. Anxiety raises blood pressure. Nothing makes a patient more anxious when you walk in and you introduce yourself as, hey, my name is Ryan, today's my first day, I'm going to put you to sleep. That raises their blood pressure a little bit. So recommendations, don't wrap it too tightly. It's going to be there a while. I mean, it's susceptible to pressure points and breakdown. So for, you know, especially like little old ladies who are very bony, you know, must be very careful. Cycle time, it has to be at least every 5 minutes. I mean, you can do every 3, some might do 3, but it's generally every 5. Inspect the site periodically, looking for breakdown, and then obviously record where it's at, what your cycle time is. Obviously, always keep all alarms enabled. Never turn the alarm off. This is just again the perineal nerve, which is if you put it on their leg, kind of susceptible to nerve injuries. So relative contraindications, so not absolute contraindications. Obviously, we know about avoiding if there's any fistula. The extremity is requiring surgery. It's obviously going to be frowned upon. You know, they prep the area and you put the cuff over it. That's a no-no. Extremity involved in a trauma, obviously not. IV PICC line, you may not have a choice if there's IVs on both sides. So if you keep in mind when you place it in the lower extremity, systolic can be higher, diastolic and MAP are lower. Forearm can overestimate, but as I mentioned, kind of a couple slides ahead, you know, kind of get that baseline of, let's say before you put the IV in, get the blood pressure in the correct spot, and then compare it to like the forearm and see like the difference to get an idea of going forward if you're going to place it in the forearm or a different area. So do that before you put them to sleep. If you can hopefully see them before they're kind of in the pre-op area. So get the baseline. Hydrostatic effects caused increased pressure in dependent limbs and decrease in the elevated. So when you're in the position, not everyone's lying on their back. Sometimes they're on the sides, either way. So physiologic effects of sitting, so especially with ortho cases, on the surface, like they may be easy, but they are not, because when they do like the scopes, they can't see very well if the blood pressure is too high. The blood kind of gets in their visual field, so they will want the blood pressure lower. Now you need to also keep in mind that that patient is sitting up. So, you know, by that very position, you know, they're asleep under the anesthetic, so the blood pressure is lower, and they're sitting up, so gravity, pressure is lower. So be very careful about not dropping it too much for too long, because, I mean, the brain needs blood. I mean, Sure, post-op, I mean, your shoulder may be better, but if your brain was starved of oxygen for an hour, who cares about your shoulder anymore? So, here ends that one.